Hello, everyone. We are going to get started shortly. Hey, everybody. We're going to get started shortly. I'm just going to let a few stragglers join us, and then we will get this party started. But thank you for joining me today. So give us just a few minutes, and I will let everybody get in, and then we'll get started. Hey, everyone. Dr. Haverland here. I'm just letting a few more people join, and then we will get this webinar started. Thank you for joining me today. Just give us a few minutes and we'll get going. Hey guys, Dr. Haverland here. I'm just letting a few more people join, and then we will get started with our webinar. Thanks for joining me today. Just one or two more minutes, and then we'll get started. All right. Hey, everybody. I am Dr. Rachel Haverland. Thank you for meeting with me in this webinar today. I appreciate you guys joining me. So through this next hour, we're going to talk, a little bit about endometriosis and hopefully some education. I do want this to be interactive though. So if you have any questions, if you have any comments, use the chat feature in the side. I would love to get to know more about you, see what questions you have. See where you're from. But if I talk about anything that doesn't make sense, or if you have any questions about it, please put it in the chat. And at the end of this webinar, we'll be able to go over some of those questions and personally answer some of those questions. I do this webinar about every month, trying to educate women about endometriosis and sometimes some of the concomitant diseases associated with endometriosis. I I really think that it's helpful just to advocate to women to talk through some of the symptoms that they're having, and just to give patients more options for treatment, and just a little bit more education about what's available for them for treatment. Um, again, I'm just letting a few more people in, but it seems like it's about time to get started. Um, All right. So Texas women, I see a few people from Austin and people in the chat. So a lot of you guys are from Texas. I do have people from all over the country, but mostly in the U.S. So Texas women, I want to say something that might surprise you. Painful periods, bloating, fatigue. This is not a personality trait. This is not something that you're supposed to just deal with. But most women have been told this is normal. This is just part of being a woman. Take something for it and move on. So you push through, you go to work, you show up for your family, you keep functioning. But underneath it, every month, your body is struggling. If you've ever thought, why does this feel worse than everyone else describes? Or why does my body shut down every month? This session is for you because today you're going to learn what actually qualifies as normal period discomfort, the red flags that most women miss, and what your body might be trying to tell you early before things get worse. Um, so, there's this normalization trap. And I think that this is really important to talk about because the pain that most of my patients experience is not normal. This is the biggest problem. Women have been taught to normalize symptoms that shouldn't be normal. If something happens every month, you assume that it's supposed to happen, but frequency does not equal normal. So let me say that again. Just because it's common doesn't mean that it's healthy. Severe cramps that keep you from functioning, not normal. Bloating that makes you look like months pregnant, not normal. Exhaustion that wipes out your day, not normal. But when you bring this up, what do you hear? Your labs are fine. Your scan looks normal. Try birth control. So instead of getting answers, you start to get managed. And then over time, you stop trusting your body. And that is very, very much a problem. So I am Dr. Rachel Haverland. I'm a board certified gynecologic surgeon and endometriosis specialist. I've worked with now thousands of women now, who many were told their symptoms are normal, until they weren't. People get normal imaging, normal ultrasounds, normal MRIs, and they're told that they don't have endometriosis, or they don't have anything wrong, but we know that there's something wrong. Just because the scans look normal doesn't mean that there's not a problem going on the inside. It just means that the imaging is not perfect. The imaging missed it. Some of my patients eventually needed surgery and some didn't. But almost all of these women had something in common. Their bodies were giving signals early that something was wrong, and those signals were missed. And I'm not here to scare you, but I do want to help you understand your body before things escalate because early clarity changes everything. Um, you know, Women very frequently are not listened to. Young women especially, they have to really advocate for themselves. And I'm seeing these women come into my office as they are struggling, but you can see them bringing in folders of information, typing out their history of their symptoms and kind of so they can have it in an organized manner. My patients have worked really hard, to advocate for themselves and to start finding answers and to sort of start fighting um, the people or the institutions that are trying to normalize the pain and this, the symptoms that are having to endeavor. And so I give huge credit to my patients for learning and advocating for themselves because the symptoms that my patients experience are not normal. So the first thing that we're going to talk about is what normal period pain actually looks like. Like what is expected for normal period pain. And then later we'll talk about what is outside of that. So what does normal period pain actually look like? So there's a belief that periods are supposed to hurt. The truth is there's a difference between discomfort and dysfunction. So normal period discomfort, mild cramping, should be temporary, and it doesn't affect your day. I think that is the most important thing. Cramping, pain, irritation, but it does not affect your daily functioning. You're able to go to work. You're able to exercise if you want. You're able to go to that meeting. You're able to go to have dinner with your friends. It does not stop your day. And I think that that is key. And it improves with basic support. So, we all have friends, and I use this analogy a lot. We all have friends that have we'll have this friend who's like, okay, I started my period this morning. I took some ibuprofen. I'm going to go for a run. I'm going to go to work. Like, do you want to have dinner later? And that's a part of your conversation. And you kind of take a step back and you're like, wait, I thought you said you started your period, but she's still able to do all these different things she was planning on. She took some ibuprofen. She can still get through her day, exercise, work, and still wants to be social at the end of the day. That is actually what I would expect in like a normal period. No, this is not stopping her day or her daily functioning. What my patients experience is certainly not this. It is very different. It is debilitating. It is on the floor, passing out, vomiting, pain that's radiating, pain that is not getting better with ibuprofen, and pain that's affecting their daily functioning. So the belief that periods are supposed to hurt is really not accurate. They can be uncomfortable. Yes, you can have some bloating associated it, but it should be temporary, it should be mild, and it should not stop your daily functioning, and it should improve with basic support. So, what is not normal? Pain that makes you cancel plans. That is not normal. Pain that radiates to your back or your legs. Pain that doesn't respond to medication. Pain that worsens over time. I've had all of these women, especially young women, who, they don't know anything different. This is how their periods have been their whole life. And so they just expect that this is what it's supposed to be. This is what is supposed to be normal. So this is normal for her because she's never had anything different. She's been pushing through it for years. But by the time she came in, her condition has, progressed significantly. She'd been to the emergency room. During her period, she's frequently passes out on the bathroom floor, vomiting, unable to keep down food, misses work every month. She's missing like 3 to 4 days of work. And the condition, her pain and her symptoms continued to worsen with time. And it's not because she ignored it. It's because she was told it was normal for so long. And your body whispers before it screams. And everybody needs to start listening to these small symptoms that may seem small at the time, but they can certainly be exacerbated. So your body whispers to you before it screams, I think is a great analogy, talking about how it's starting to give you some of these symptoms, some of these kind of tools to understand that something's not correct, that something inside your body is hurting and it's not improving. And so the first thing we talked about is what a normal period pain actually looks like. The next thing I want to talk about is the red flags that most women missed. So here's where it gets important. It's not just about how much pain you have, it's also the pattern. So red flags are when the pain is worsening with time. Rather it's getting worse month after month or year after year. I have some women that are on, like as a young person, they got put on birth control, for example. And throughout the years, their pain is getting worse despite being on birth control. Like every year they're like, hey, I'm on this medication, but my symptoms are getting worse. I'm starting to have worsening pain. I'm still having more symptoms. I'm starting to have radiating pain that's going to my back or down my legs, like sharp, stabby pain. Some people start to have bowel symptoms. Some people start to have bladder symptoms. You're like, despite being on these medications, my symptoms are worsening. Or like a few years ago, my pain was not that bad with my cycle, but now every month I'm really debilitated. I'm seeing heavier bleeding, for example, or I'm starting to have symptoms outside of my cycle. So another red flag is pain that doesn't go away after your period. So pain, and that's typically kind of the classic evolution of how endometriosis starts. It typically starts with pain during your cycle. And then as the endometriosis progresses, you start to have pain outside of your cycle, rather with ovulation, the week before your cycle. For most women, the week after their cycle is the best week if they're going to have one, because the endometrium has has shed and your hormones are kind of at the lowest of the low and they're starting to work their way back up. Um, but pain that does not improve their cycle, classically women's pain with endometriosis starts with cyclic pain during their cycle, but then as it progresses, you start to have pain outside of your cycle, or it's affecting your other organ systems like your bowel, your bladder. It can affect painful intercourse and then ultimately can affect fertility. And so, some of my patients also have more of a silent endometriosis with less symptoms, but they realize it once they're trying to conceive. So another red flag is fatigue that feels disproportionate. The most common symptom of endometriosis is fatigue. And I read this study recently when I was getting ready for a presentation because I wanted to make sure my PowerPoint was up to date. And at first, I was kind of annoyed. I was like, well, fatigue, everybody has fatigue. This isn't really helping me. How is this helping me like differentiate endometriosis? But it makes so much sense. Your body is chronically fighting this inflammatory process, and it leaves very little left in the tank for your daily functioning. And that's why the fatigue creeps up on you. But this chronic inflammation, your body is giving everything that it has, all of its energy to keep this at bay, to support your immune system, to decrease the inflammatory markers. And at the end of the day, there's very little left. And I see women, they're like, I nap now and I've never napped before. I don't have energy to make dinner at the end of the day. I go to bed at 6 o'clock and I can sleep all the way until 8 a.m. I'm sleeping like 14 hours a day. I have nothing left in the tank. And that's because your body is giving all of its energy to fighting this chronic inflammation and this chronic disease. Um, so we talked about the red flags, symptoms that are getting worse over time, bloating that doesn't go away after your period, fatigue that feels disproportionate, pain during ovulation, and not just menstruation. So there's something called middle smirts, which is pain during ovulation. And some people do feel this, but women with endometriosis are especially exacerbated. You feel more sharp stabbing pain, you feel pulling pain. And again, it's because there's inflammation in your pelvis. Your nerves are already excited. You're sitting at this inflammatory process. And so when you ovulate, it does create a cyst and there is some inflammatory process there on the ovary. And sometimes when you have endometriosis, your body is already, starting to fire some of those nerves. And so when you ovulate, the pain can be significant. It can be exacerbated. And so many women without endometriosis, they may have some soreness or a few like intermittent pains that they feel with their ovulation, but women with endometriosis sometimes feel debilitated, like they have appendicitis or they're getting stabbed, or they're worried for ovarian torsion because their pain can be, so severe related to endometriosis. And ovulation, even though it is a small inflammatory process, really just pushes them over the edge. And then the last one that is another red flag is digestive issues. So many of my women have chronic constipation, alternating constipation and diarrhea. If you're seeing the cyclic nature of your digestive system, that's another red flag that there may be something going on. Many women with endometriosis have chronic constipation, and that has to do with the inflammation of the nerves and the peristalsis of the colon. The endometriosis can affect the nerves and that inflammation around the colon, and so it doesn't peristalse as well. Sometimes it's hard to get the stool burden through the canal of the colon because the endometriosis is causing the inflammation, affecting the nerves and affecting the peristalsis of the colon. What's frustrating with endometriosis is that sometimes even after we remove the endometriosis from around the colon or the rectum with surgery, sometimes the chronic constipation doesn't completely resolve because of the chronic damage on the nerves and some of the musculature that is used with peristalsis through the colon. And so it certainly is something that I think is very important to understand, that if you've been diagnosed with IBS or chronic constipation, frequently it's also associated with endometriosis, not a separate entity. And it's certainly a red flag, to consider. So these patterns that you're experiencing are not random. They're signals. One woman came to me thinking that she had just a low pain tolerance. Everybody told me I've been very sensitive, I have anxiety, and I have a low pain tolerance. Well, she didn't. she had a pattern that nobody ever mapped out. Nobody really talked to her about these symptoms. She'd been diagnosed with interstitial cystitis affecting the bladder. She'd been diagnosed with IBS affecting the bowel. She's been told she has a low pain tolerance during her cycles, that periods are supposed to be painful. But once you really put it all together, you realize that there's definitely an underlying etiology. And once we understood it and talked to her about it and listened, everything started making sense. We were able to find connections between the different organ systems, watched her pain as it progressed as she was a young woman, into her 20s, how the pain has worsened with time, how the pain is starting to become outside of her period, bloating that is getting worse and not going away after your cycle, fatigue that is becoming, exacerbated, pain now during ovulation, bowel and bladder symptoms. Likely they're all related with the endometriosis, not necessarily separate entities. And so I think that this is, really important to understand kind of what these red flags are, and also differentiate what normal period pain actually looks like, and then identify these red flags, because most of my patients with endometriosis are not experiencing expected normal period pain, and that's because some of this has been normalized, and been, patients have been told, periods are supposed to be painful. This is normal. It's a part of being a woman. This is normal for you. But let me tell you, it is not normal. You should be able to function throughout your day. You should be able to go to work, take some ibuprofen, go exercise. This should not affect your daily functioning. And when it gets to that point, there's something wrong. Even if you've been told it is normal, this is not normal. And so I'm going to go to the chat now and answer some questions, and then I'll go back and kind of continue talking about kind of expectations for periods and normalization of endometriosis and some of the symptoms that we experience. So one of the things that I wanted to mention is during this webinar, there is a link. So in this link, you have the opportunity to make an appointment. Now, I just want to be clear, this appointment is not with me. This appointment is with my office manager. Her name is Cyrus. So during this appointment, you'll be able to talk with her. You'll give her your information. She'll talk to you about scheduling an appointment. And we do have some saved appointments for my webinar patients. And so just so you know, this visit that you're making is not with me directly. It is with my office manager, Cyrus, and she'll be able to get you on the schedule. But we do have a few spots that we save for our webinar patients, so you'll be able to get in a little bit earlier. Right now, we're booking in July, August, but like I said, we do have a few spots that are open before then. So I'm going to go to the chat and see some of the questions that have been put up. All right. Let's see. Um, this patient said she has chronic digestive issues and the GI doctor can't find anything wrong. That's also very common with endometriosis. So women with endometriosis frequently have alternating constipation, diarrhea. Sometimes you're diagnosed with IBS. Many times you have normal endoscopies, right? An EGD is an upper endoscopy, or colonoscopy, which is a lower endoscopy looking inside the colon. Many times they biopsy, they can't find anything abnormal. So why are you having chronic constipation? Why are you alternating between constipation and diarrhea? Why are you so nauseous? A lot of my patients have like a slowed motility. They call it gastroparesis, or the food is not really moving through their colon as you would expect. And that's common with endometriosis. It's because this inflammation is slowing that motility and slowing some of the symptoms that they're experiencing. But frequently endometriosis is associated with GI. And one thing that's a little bit more difficult about endometriosis is that it doesn't follow the rules. Some women have every symptom of endometriosis. They have painful periods, they have painful intercourse, they have bladder symptoms, they have bowel symptoms, they have the inability to get pregnant, bloating, pain that's radiating down their legs or to their back. However, some women don't have every symptom. Some women just have GI symptoms, for example. They're like, GI is my only symptom. I have nausea. I have chronic gastroparesis. I have difficulty keeping things down. I'm very sensitive to nausea, and different foods can cause me to be nauseated. So it's very common to see only GI symptoms. Sometimes it's common to see bladder symptoms as well. Like my only symptom is that my bladder is really painful. It hurts. It feels like I have a UTI, but when they check my urine, it never grows bacteria. I've tried many different antibiotics. Nothing is improving the bladder symptoms. Sometimes my patients just have trouble getting pregnant. They're like, I've never really had painful periods, but we've been trying for a year. I'm ovulating regularly. My husband's semen has been evaluated, and we're not getting pregnant. And so endo is tricky because it doesn't follow the rules. Classically, women have a lot of these other symptoms kind of pulled together, but it's not a way to rule out the disease if you do not have every symptom of endometriosis. And I think that that's really important to just have an open outlook about endometriosis and how it can affect the person individually. This is not an algorithm. There's not a one size fits all as far as endometriosis patients go. It is imperative to listen to your patients, understand their symptoms, and help tie it all together. And I think that's a problem with our training, and some of our in OBGYN residency. I think some of the textbooks and some of the education that we've got about endometriosis is flawed. And so sometimes providers, if you don't have every symptom of endometriosis, they kind of rule it out. Well, you can't have endometriosis because you don't have bladder symptoms, or you can't have endometriosis because you don't really have pelvic pain, or you can't have endometriosis because you don't have heavy bleeding. That's absolutely not true. And it's important to be able to kind of tease out some of these symptoms that patients have individually so that we can tie it all together and find the underlying etiology. The average endometriosis patient has seen 7 to 10 doctors before they're diagnosed with endometriosis. And I've seen that in the chat too. They see a GI doctor, they see a urologist, they see an endocrinologist, they see an immunologist, they see somebody, a primary care doctor. They may even see OBGYNs. But many times they've seen multiple providers trying to look at these different etiologies of their symptoms specifically without finding answers. And I can imagine that that's very frustrating. It also takes, 7 to 10 years, to start, to get a diagnosis. So these women, usually young women, are advocating for themselves, talking about their symptoms to different doctors, and nobody's really tying it all together or taking their symptoms seriously. Maybe they're being told it's normal to have pelvic pain during your period, but anything outside of what we discussed earlier is certainly not normal. And one more thing I wanted to talk about, with endometriosis is sometimes it's difficult to diagnose because you don't always have um, a finding on imaging, right? And somebody mentioned this in the chat. So can you be diagnosed without abnormalities on imaging or without surgery? And the thing is you just have to listen. Listen to your patients, understand the disease process, how it affects the different organ systems. Understand that imaging is not perfect. Ultrasounds, MRIs, these certainly are not perfect. And they are a helpful tool. They're not wrong, but frequently with stage 1 or stage 2 endometriosis, you can't see anything on imaging. The organs are not yet fused together. The implants of endometriosis are more superficial. Sometimes they are deeper, and the MRIs and ultrasounds just miss it. But it's very important to have a high suspicion for endometriosis, even if you do not have abnormalities on imaging. And that's common. Probably, I don't know, 33 to 40% of my patients, a third to almost half of my patients have early stage disease. And so most of the time they have normal imaging. And again, normal imaging does not rule out endometriosis. It just means that we can't see what's wrong. But you have to trust your body and trust your instincts. Just because you have, quote, normal ultrasound or normal MRIs, that does not mean that everything inside your body is normal. And your body is telling you that. And kind of something I mentioned before, your body whispers before it screams, and it's starting to tell you, these are your symptoms. This is not normal. This is hurting my body. This is inflammation. And you have to listen to it. You have to trust your instincts and advocate for yourself when you know that there's a problem. Okay, let's see. I'm going to go through some different questions. Um, let's see. What specialist is best for adenomyosis, and does adenomyosis and endocrinologist go hand in hand? So adenomyosis is best treated with an OBGYN or really an endometriosis specialist because at least 30% of women with endometriosis also have adenomyosis. So adenomyosis, for those of y'all that haven't joined me before or this is their first time, adenomyosis is a disease of the uterus. The lining of the uterus grows into the muscle wall, and the uterus becomes heavy, becomes boggy, becomes inflamed. The uterus should be hard like the back of your hand. And so when a uterus has adenomyosis, it's very soft. It's sponge-like. It's kind of edematous. It's like your ankle if you went on a long car ride. Like you can push into it and it takes a while for the tissues to come out. That's a uterus that has adenomyosis. You can also see a difference in the coloration. We call it mottled in appearance, but it looks kind of like lace. Like some areas are dark, some areas are lighter, and then the tissue integrity is very soft. So really, an endometriosis specialist or an OBGYN should be managing adenomyosis. Now, unlike PCOS, which very much has like an endocrinology type underlying, problem with the insulin resistance, adenomyosis actually usually does not. It's more associated with inflammation, radiating pain, bloating. I kind of pull out the classic adenomyosis symptoms. It's pain during your period, pain that radiates to your back, down your legs, bloating, heavy bleeding, feeling like you have like a bowling ball in your pelvis. That's kind of classic adenomyosis. The good news is that adenomyosis is treated very well with progesterones. So endometriosis does not always respond to progesterones, but adenomyosis of the uterus frequently does, rather with a progesterone IUD or oral progesterones. So frequently that's how that's treated, unless you're ready for a hysterectomy. Hysterectomy is definitive treatment for adenomyosis. So adenomyosis after hysterectomy cannot recur. So that is the good news. But it is a big surgery to undergo, and you have to understand the repercussions of a hysterectomy. But the good news is once after the hysterectomy and you heal, you have zero risk of recurrence, at least as far as the adenomyosis. Okay, so I'm going to kind of go down a little bit. Let's see if I can find um, some more people on the chat, and then we'll go back to the webinar. Okay, let's see. Somebody said, is there a certification for doctors who specialize in endometriosis? I feel like there's a lot of docs that only care if you're pursuing fertility. And that's true, unfortunately. Yes, there's a few different websites. I Care Better is one who is vetted endometriosis surgeons. Now, they are starting to allow people that haven't submitted videos to be, quote, vetted. And so I would make sure to look for that, to find endometriosis specialists that have submitted videos, so that can kind of prove that they do excision surgery and they focus on endometriosis. Nancy's Nook is one. They're kind of vetted by patients, not necessarily other surgeons, but those are two places that I would recommend starting your journey for looking into endometriosis specialist. And it is true, unfortunately, some endometriosis doctors are only focused on fertility. In my practice, probably half of my patients are fertility patients, but the other half are pelvic pain specifically, rather not ever wanting to have children or not wanting to have children currently or not in the near future. But it's something I always talk to my patients about. I think it's really important to ask these questions about their desires and goals for fertility, as that's not everyone's primary goal, and it certainly doesn't have to be. So we talk about that in my visits. Again, before we get back to the webinar, there is a link in the chat where you guys can try to help schedule with me. So on that link is an appointment to meet with my office manager. So I just want to clarify, this is an appointment with my office manager. It is not a direct visit with me. But she does have a few spots that are open, so she can get you in a little bit earlier than typical for a visit with me. But at that visit, you'll get your insurance information. She'll talk to you about what it looks like to schedule an appointment with me, and then she'll get you on the books. And like I said, with the webinar, I do save a few spots for earlier availability than my traditional wait time. But you can use that link in the chat to have a visit with me. But essentially, the time is with my office manager, not with me directly. Okay, so let's go back to the webinar. Okay, so first we talk about like the normalization trap. Women have been taught that, to normalize symptoms, that periods are supposed to be painful. And that is not accurate. What normal period pain should be is treated with ibuprofen or Tylenol. It should be temporary, mild cramping, not affecting your day. What is not normal is when you have to cancel plans, you can't go to work, you're vomiting. The ibuprofen or heating pad does not help. Pain that's worsening over time, and the pain that starts to come outside of your cycle. And so these are the red flags. Symptoms are getting worse with time, rather month after month or year after year. Pain that's not resolving after your period. Fatigue that is disproportionate. Pain happening again outside of your cycle during ovulation, the week before your cycle, and before you know it, you're having pain almost all the time. And then it's GI symptoms or bladder symptoms that cycle with your period. That makes it more indicative of having an underlying problem consistent with endometriosis. So, why does waiting make it harder later? So most women are told, if it gets worse, then we'll look into it. But here's the problem. By the time it gets worse, it's often more complex. Pain patterns become integrated, inflammation builds, and the nervous system starts to adapt. And what could have been addressed early becomes harder to untangle later. So this isn't about panic, but it's about paying attention sooner, because early intervention doesn't just reduce pain, it protects your long-term health. And I think this is imperative to understand. One of my goals in my practice is to try to treat women earlier. No young woman wants surgery, but I do think that it is very important to try to catch the disease earlier. Because endometriosis only does two things. It rather stays the same or grows with time. And it's growing from your estrogen and your hormones, certainly. But even if we take away the estrogen, we put you on medication that stops the estrogen production, endometriosis has aromatase properties that it can use to make its own estrogen. And so even if we take that away, it can still grow from other hormones. That's why women can have endometriosis postmenopausally, or you can even have endometriosis before you have your first period. But it is imperative to try to treat this early. One thing that I mentioned is kind of the nervous system. So there's a central sensitization of pain. Your body starts getting used to having pain. It's used to having this inflammation, and your brain is used to starting to get used to feeling these pain receptors as pain, pain, pain. And so the earlier we can treat the underlying etiology, the better we can reverse some of this long-term sequela on the central sensitization of pain. And it takes time. It takes a lot of time. Nerves heal very slowly. And sometimes it takes referrals to physiatrists or pain management specialists to help with that reset of that central sensitization of pain. But the nervous system is adapted to the pain. And so if we can shorten that period where the body is feeling these symptoms, it's easier to reverse long term. When somebody's had these symptoms for 15, 20 years, it is very difficult to start to reverse some of that sequela because your body is so used to feeling pain. And even after we remove the underlying etiology, the nervous system continues to feel the pain in that way. So if we address it early, shorter, time onset of symptoms, we're able to reverse that. Also, as the endometriosis grows, at some point it can affect fertility. And I mentioned earlier in my webinar, this is not the only goal of my patients, but if we just wait, the endometriosis progresses. And as it progresses, it can get to the point where it's affecting the ovaries. It can get to the point where it's affecting your fallopian tubes, and make fertility much more challenging. So my patients that come to me with fertility, we try to treat them, right away. The earlier we treat the endometriosis, the better chances that it doesn't affect fertility down the road. I do, perform like specialized tubal recanalization, opening the fallopian tube, working on the fallopian tubes. However, if the tube is dilated, consistent with what they call a hydrosalpinx, where there's fluid filled in the fallopian tube and it's dilated, You have to have at least 4 centimeters of normal tube to be able to reconnect the tubes. You have to have 4 centimeters of normal tube, or the tube will not function, and you have increased risk of ectopic pregnancy. And so at some point, if you have that true hydrosalpinx in the fluid has filled the fallopian tube, dilated to the point where it's not functional. Unfortunately, if you don't have 4 centimeters of tube, it's unable to be fixed at that point. But the goal is to not get there. I actually had an earlier patient today. She was talking to me about, she's complained about these symptoms. Her body was whispering to her, telling her these symptoms were not normal. She was advocating for herself. Her doctors kept getting ultrasounds that were normal. And then eventually her pain got so bad, she went into the emergency room. And at this point, she has stage 4 endometriosis. She had bilateral endometriomas. The uterus is fused to her rectum. And this was just 6 months after her last imaging scan. And nobody took her seriously. And she was trying to advocate for herself. She was trying to, tell doctors and tell people that she was having these symptoms. And unfortunately, she was never really given the opportunity for surgery to treat the endometriosis, or to find options outside of birth control. But she did try, but unfortunately had pretty significant symptoms. And so the goal is to listen to your body, believe women, talk to them about their symptoms, try to connect the dots, and understand how the etiology of endometriosis works together, so that we can put a plan together for an individualized treatment to get the best outcome. So we talked about why waiting makes it harder. And it's impossible to know, is it going to be 6 months? Is it going to be a year? When is it going to continue to progress? And honestly, we don't know. Sometimes the progression has to do with inflammation. Sometimes the progression has to do with an immune response. Like if your body gets sick, the endometriosis kind of takes advantage of the immune system being down. Sometimes it's unknown. Why did you have no symptoms for 20 years, and all of a sudden when you're 25, the endometriosis grows exponentially? So some of these answers we don't have, but the earlier we treat the endometriosis, the better the outcomes, not just for fertility, but also for decreased risk of recurrence for the endometriosis and improved symptoms after surgery. So my goal in my career is to try to treat women earlier, catch them within the first year or two that their symptoms start, rather than waiting after they've had endometriosis and symptoms for 5 years, 10 years, 20 years. It's imperative to make sure that we're listening to our patients and giving them all the options. And surgery is not always the option, but it's imperative to give them all their options so that they can make the decision that's best for them. Okay, and so here's what I want you to take away from this webinar. If your periods feel overwhelming, if your symptoms don't match what you've been told is normal, this is not in your head, and it's not something you have to just live with. It means your body is asking for a closer look, and the earlier you listen, the easier it is to respond. It is easier to reverse some of the sequela for endometriosis. It's easier to treat surgically with less risk of recurrence, less risk that it affects your fertility. We can start to reverse that central sensitization of pain and reset the nervous system. We can work on the pelvic floor with physical therapists. Sometimes acupuncture can be beneficial. Work on the GI tract and that chronic, IBS, constipation, diarrhea, or maybe we never even get to some of these symptoms if we can try to catch it early. But it's imperative to listen to your body and what it's trying to tell you. Because endometriosis is very much a disease of experience to diagnose. And it's also a disease that frequently is misunderstood. And I think that, that it's important to talk about this, to have webinars talking about endometriosis, to have advocacy groups for these, even Facebook groups on social media, for people to talk about some of their symptoms, to understand that these symptoms are not normal. What they're experiencing is not normal. Just because you've always had these symptoms, just because your mom always had these symptoms, does not mean that it's normal. This may be familial or genetic. And so it's really important to listen to your body and to understand what to look for. Look for these red flags, understanding what is expected of a period pain and discomfort, and what is not. So, with a consultation with me, this is exactly why my team and I offer these private consultations. We walk you through your symptom patterns, identify what's normal and what's not normal, what needs attention, help you understand what your body is signaling, and then map out the next best steps. This isn't about just jumping to treatment. It's about understanding, because once you understand what's happening, you can make the right decisions for your body. We only have a limited number of consultations each month, but these are in-depth, personalized sessions. Once these spots are filled, we close the calendar. With the webinar, we do have a few open spots with earlier visits. So if you use that calendar link in the chat, you'll be able to get a meeting set up with Cyrus, my office manager, and she'll be able to help work to get you on the schedule. Remember, so that meeting that you use on the calendar is not a direct meeting with me, but rather a meeting with Cyrus to be able to talk with her and get on the calendar. But if you are tired of guessing, wondering if what you're feeling is normal, or if you're trying to catch something before it gets worse, struggling with fertility, having some of these other, symptoms, the GI symptoms, the bladder symptoms, the pain with intercourse, now is the time to act. Book your consultation before the schedule fills. I would be honored to see you. You know, you deserve answers, and you deserve to have, relief. Imagine knowing whether your symptoms are actually normal, what your body has been trying to tell you, and what to do next without confusion. There's no more minimizing, there's no more second guessing, no more waiting for things to get worse, just clarity. And clarity changes everything. So I look forward to meeting with you guys. Thank you for meeting with me with this webinar. I think it's really important to kind of squash this normalization of period pain. To understand what is expected, and what is normal, and why what you're experiencing is not normal. And really just advocating for women in this space, whether it's for your sister or your, young daughter or child, but really understand that endometriosis is debilitating. And the earlier we catch it, and the earlier we treat it, the better our outcomes are, with longevity, protecting the ovaries, with preserving options of fertility, with reversing the central sensitization of pain in the nervous system, the pelvic floor, and better chance the endometriosis doesn't recur. When we operate on women an early or moderate stage disease, your chance of recurrence is much lower if we wait until it becomes stage 4. So if we catch endometriosis at stage, 1, 2, early stage 3, your risk of recurrence is about 10 to 15% at 5 years. Once you have an endometrioma, or you have stage 4 disease, your risk of recurrence gets higher, closer to 30%, especially with an endometrioma. And so it's important to try to catch it earlier so that you have better long-term outcomes, better chance that the endo doesn't recur, and better chance your symptoms improve. So I'm going to go to the chat again and answer, a few more questions here. Let's see. So this person said, is it ever too late to treat? I'm 42. It is never too late to treat. I even see postmenopausal women that are, about once every 6 months, I see pathology positive postmenopausal endometriosis. The average age of menopause is 52, but at 52, there's no guarantee that your symptoms will resolve, even with menopause, which is frustrating and kind of frightening. And so if you feel like endometriosis is affecting your functioning, I think it's never too late. 42 is young, because that's about my age. So you have to be young as well. But I think that it's really important to advocate for yourself, because suffering, the way that endometriosis works, you're suffering, it's not going to get better on its own without some sort of intervention. And it's also important, as you're older, to think about adenomyosis, that inflammation of the uterus that may be contributing with some of those other symptoms. Let's see. Is there a correlation between PMDD and endo? So you have big fluctuations in your hormones, throughout your cycle, which certainly can contribute to like depressive syndromes or distress syndromes, or mental health changes throughout the cycle. Women with endometriosis certainly at higher risk for this, also because of the associated pain with their cycles. And so when your body is anticipating this big, painful, inflammatory response, it also can affect your mental health. And sometimes you have bigger hormonal swings, especially in your cortisol. And so you certainly are at a higher risk category, for that. So somebody asked, do you think extraction is more beneficial than ablation surgery? So excision, we call it excision surgery. So essentially that means it's going in and removing the endometriosis. And it absolutely is more beneficial. There's actually no evidence that ablation, which is going in and burning the endometriosis, gives any benefit, either for fertility or for pain improvement. And the endometriosis comes right back. When you burn an area, it leaves behind an inflammatory response. You see the scar tissue form. Endometriosis is kind of like the tip of an iceberg. If you just shave off the top to the level of the ocean, there's a lot of endometriosis underneath, and you're not treating it at all. And so with ablation, your risk of recurrence is almost 100% because it's never really treated. All the cells aren't damaged. And so with excision surgery, we're very delicately and completely removing the abnormal cells so that there's a better chance that the endometriosis doesn't recur and better chance that your body can start to heal and reverse some of the long-term sequelae from the endometriosis. Excision surgery is also the only way that's proven to improve fertility outcomes, both with natural conception and through IVF. So both of these areas have shown improvement with studies, but only through excision surgery. All right. Let's see. You know, um, Someone says my daughter's only 15 and we suspect endo. We're unsure where to go. It's hard to know, and I do realize that young women, you don't want to, first line go into surgery, but it certainly is reasonable. Sometimes birth control is beneficial. It can help subdue some of the endometriosis, especially with the progesterones. Some women want to wait for surgery for, a treatment with a excision and then consider, doing progesterone if they feel like the adenomyosis is still present. It's hard to know. And birth control certainly can have side effects. Sometimes it works beautifully and helps, and people can get through a few more years before they have to have surgery. But it's really important just to not let her, let them suffer. Make sure they're working on their diet, decreasing the inflammation, pelvic floor physical therapy, other ways to decrease their inflammation. If they're hesitant to do birth control pills, they can do progesterone only to try to subdue the inflammation. Or, come talk to me if you feel like, surgical excision is the next best step. And I do include surgical excision in my treatment plan. I think that it's the gold standard. If you've had a different type of surgery, like an ablation surgery, there may be endometriosis left behind. It's hard to know, but I do implement excision surgery in my treatment plan, and then I utilize the other modalities. So we have pelvic floor physical therapy, we have nutritionists, we have people that help with acupuncture, physiatrist, pelvic pain specialist, but other people to help us with our, management plan of endometriosis. And like I said, I'm a surgeon. I do think surgery has a lot of benefit for endometriosis. It's the gold standard for treatment and a diagnosis. With that being said, surgery is not for everyone. And so I do try to implement a multidisciplinary, appropriate multidisciplinary team so that we can get our best outcome. And a lot of that has to do with lifestyle changes to decrease the inflammation. I do talk about hormones. Some people do benefit from progesterones or hormones, especially if they have ovarian cyst or adenomyosis. That's going to give them a significant benefit in helping in those areas when it comes to that. But I appreciate you guys, sticking out with me for the last hour. Endometriosis is, a really difficult disease. It affects people in many different ways. It steals time from us because it, affects our social activities, affects our work. It can affect our fertility. It causes pain, and with the pain can come anxiety and depression because you're hurting all the time. You're unsure if it's going to get better. I hear you. I understand you. I'm here to help. If you'd like to make a visit with me, I'd be happy to sit down and talk to you about some of your options. We here at Endometriosis Center of Excellence, we are a surgical subspecialty, but we also implement those other multidisciplinary approaches, including nutrition, physical therapy, acupuncture, mental health specialist, pain management, and talking about hormones. Now, I don't always, manage hormones long term. Usually, I kind of help you get into a local doctor or an OBGYN to help manage that long term, but just giving you different options that maybe you haven't been given before, I think is really important. Advocating for yourself, understanding that what you're experiencing is not normal. You've been dealing with this for a long time. And just because the imaging does, we can't find anything, just because you've been told periods are supposed to be painful, if you're experiencing those red flags, this should be treated. This is not normal. If it's affecting your daily functioning, if it's pain outside of your period, if ibuprofen isn't helping, if you're vomiting, if you're having fetal position on the floor, if you're unable to function, that's not normal. So listen to your body as it's whispering, trying to tell you, what's going on. But it's been an honor to talk with you guys for the last hour, and educate a little bit about endometriosis and understanding, the normalization trap that period pain should not be that extreme, and talking through some of the red flags, and other symptoms that may be associated with endometriosis that are red flags, so that we can connect the dots and find a treatment plan that gets to the root cause. So I look forward to seeing y'all hopefully in a clinic visit. This will be posted on our YouTube channel. But I hope you guys have a good rest of your Wednesday, and have a good week.